Hello, Mark. Can you hear me?
Unmute myself. I can hear you just fine. Thank you.
Yeah, perfect. Nice. Nice to meet you. I'm gonna be chairing your session today.
Great. Well, thank you. It's nice to meet you as well. You are Miguel, is that correct?
Miguel. Yeah, exactly.
Okay. Very nice to meet you, Miguel.
So let's wait a bit for the people to come in to the session. So if
That's great.
you can share your screen just to check that everything
Yep.
works fine and so on. Thank
Do
you.
that.
Okay, nice.
I'm going to share my screen a bit differently so we can make sure there's a little bit of audio in the clip. So I'm going to back out of this for just a moment.
Okay, yeah, no worries.
Make sure I'm doing that the right way. Share sound. Miguel, where are you?
So I'm from Spain, but I'm based in Brighton, the UK.
Okay.
So I'm at the University of Sussex.
Okay. Very good.
Okay, so I see Carl is here already. So yeah, I guess we can start. So today we have Marc Broberg. He's going to be talking about reframing the life experience of persistent dizziness, active inference insights. So go ahead whenever you want. Thank you.
Great. Well, thank you so much for having me here. Having me back, actually. I was here a few months ago when your group was kind enough to give me an opportunity to present some of the questions I had about the vestibular system. And so that was maybe perhaps a bit of a low road approach. And so now looking at the lived experience, big picture assessment, and then kind of taking a deeper dive, I'd say that we're probably engaged or embarking on the high road a bit, although there will be some other elements in there. I'm Marc Broberg. I'm a physical therapist here in Southern California, and I'm grateful to be here with Mick Thacker and Jorge Estevez, both of whom have been collaborators that came about from previous interactions with this group and suggested by Carl. So I'm very grateful for this collaboration, for their mentorship. And I'm also very grateful for Carl in introducing us and also making important contributions to this endeavor. So I wanted to acknowledge them and acknowledge everyone here. And I want to give a special acknowledgement to the patients who have really informed this perspective along the way and their stories. And in particular, I do want to highlight one person, and he gave full consent for the interview. But I thought that bringing the patient perspective to the table here from a real person that's had a real experience with dizziness would hopefully add some value. So we're going to be hearing from him. I know we don't always talk about goals in this world, so I thought preferred observations might be appropriate here, but I really want to formulate an integrative active inference account of persistent dizziness that includes phenomenology and activism and ecological psychology. And based on that view, like to identify targets for clinical interventions, and then importantly, really want to engage the group here, what maybe we missed, what future directions, and with in mind that there is a paper forthcoming, and the IWIA AI conference coming up that I'm very excited about as well, and hope to see many, if not all of you there. So every person with persistent dizziness starts off by having an acute episode, right? And so when I say dizziness, I'm using a general term. It could be vertigo. It could be really any sense of challenge to perception, particularly as it relates to balance. And fortunately, most folks who do have an acute episode of dizziness will recover within about 3 months. For the unfortunate 25%, if they have symptoms that continue beyond that time, the road forward gets very difficult for them. So they have a disruption in their lives, in their productivity, and in their subjective well-being. And ultimately, the numbers invert for recovery. So looking beyond 8 years, there's a group of individuals with persistent dizziness. Only about a quarter of those felt as if they had fully recovered, and the majority of the ones who did not feel that they were fit to return to their lives as they once knew them. So that's the context here. I want to refer to an entity that is gaining the most, it's kind of the foundation in the literature when we talk about persistent dizziness, and that is persistent postural perceptual dizziness, 3PD, triple PD. I am using that as context and as a framework for us to consider as a condition of persistent dizziness. But there are other iterations. This was previously known as phobic postural vertigo, chronic subjective dizziness. You can still apply, I would say, these principles to someone that maybe doesn't quite fit that category. They have vestibular migraine. They have other conditions like mal de débarquement. I am including all of those under this umbrella, and so I'm not going to get too caught up in the nosology here, but I do want to kind of give a sort of a foundation here. So this is persistent dizziness by definition. So it's not specifically provoked like a positional vertigo necessarily, but generally upright postures, exposure to active or passive motion, including visual stimuli, tend to trigger it or tend to exacerbate the symptoms. And it can be brought on by any event that causes dizziness, unsteadiness, or imbalance. So this could be from the vestibular system. It could be a dizziness episode from something like a concussion or something like whiplash, any type of trigger that can cause one to have a disruption in their perception in and around balance. And this persists despite the resolution of that initial trigger. And so the symptoms cause, as we've seen, significant distress, functional impairment, and they're not better accounted for by another diagnostic disorder. And that does not mean that there's mutual exclusivity. It just means if there is another diagnosis that better explains this, that excludes something like triple PD, then that is a rule out. So let's just look at this model here. So this is from the important work of Jeffrey Staub, very recent. This is the most recent pathophysiological model of what happens to the person with something like 3PD, right? So this is 3PD in particular. As I mentioned, there's a precipitating event. And then there's this acute stage where these appropriate adaptations. So the person is, if you can imagine, experiencing symptoms of dizziness, say vertigo, lightheadedness. They just feel off. And so by definition, they're motion sensitive. And so they're going to engage in high risk postural control strategies to try to control their balance. So that's usually like stiffening the trunk, stiffening the legs. And they're also very sensitive to visual and somatosensory stimuli. Fortunately, as I said, most people get better. They have this recovery process. But for the unfortunate quarter of everyone who has this, they go on to have chronic motion misperception. So they are excessively vigilant. They have low motion detection thresholds. So these continue on. And really the theme here put forth by this model is that the person has now gone from someone who moves fluidly, who prioritizes mobility, to now they're prioritizing stability in this ongoing context of heightened motion sensitivity. There's symptomatically, it sort of feels like swaying, a rocking, if you will, and just not really being able to maintain their balance. So importantly, all the systems seem to be involved, from the conscious control of the situation all the way to peripheral reflexes and visual sensitization and so forth. And so there's this excessive effort put towards controlling one's balance that is conscious and motoric and sensory based as well. This model is based on optimal control theory. So the idea here is that the person is trying to operate under the imperative of minimizing a cost function, and we can talk about that as we go here. So as a clinician, as someone who's trying to be up on the literature and reading the latest and greatest on pathophysiological models, I'm feeling like, okay, now I have a good understanding. So this is the lived experience of the clinician as well, right? I have a good understanding of what's going on with someone with 3PD. So I think, and then in walks a patient like John.
What were the symptoms like when they first came on?
Well, I do a lot of physical. I'm a woodworker, and I do a lot of. So I work a lot in my wood shop, and so I'd be working at doing a task, and I would start to feel not very well balanced or a little woozy, and that was unsettling. But it was brief, and I could then continue with my work and sort of very happily ignore the fact that something unpleasant just occurred, and that and the hope being that it wouldn't happen again. And then when it happened again, but then disappeared pretty quickly, I thought, okay, well, I can just maintain the same attitude, and until it got to the point where it became more persistent, and I had to recognize that there was something going on, and try to figure out what was happening, so that I could maybe solve the problem.
So what was that sensation like when it came on? You had mentioned a wooziness.
Yeah, it's wooziness. It's kind of like, I think, what people experience when they get seasick. Like the ground is sort of moving below you. You're kind of swaying.
Is that how it continued, or did anything change with regards to the quality of your symptoms and what you were feeling?
I just think that no, not really. But I think that it's just the frequency, where well, actually, no, that's not true. Fatigue. I began to get really tired, and then I would need to rest. And when I would lay down on a bed, the symptoms would abate, and I could just lie there quietly and happily relieved of the symptoms. But sometimes I would, take a 3-hour nap, and then as soon as I went from lying down to sitting up, the symptoms would come right back and they'd be just as bad. And that was very depressing. So yeah, I misspoke a minute ago. Things did change radically in that regard, in that I started to become depressed about it, and think that this is the way my life is going to be from here on out. There's no way out of this, and that was hard.
So what we end up with in the clinic is sort of this tale of two patients, if you will, right? We've got our model of what we feel is going on pathophysiologically. And it's very informative, right, as far as the process. But then in walks the patient, and we're asking, we're having our mind things like, okay, motion sensitivity, okay, we're under this imperative to constrain mobility and to prioritize stability. And then when you ask someone about their symptoms, it's necessarily entangled in who they are and who they feel that they were and who they fear that they're becoming. And so that adds an entirely different perspective. So it's literally a tale of two patients. And so I think what we can do here is build a bridge with phenomenology and to really, yes, consider this experience of the person, the lived body, right, as they're experiencing it, and to also not neglect the important work that's been done to help model the actual process. So that's where we're going with this. The important qualitative work that's emerged more recently, Ryan Gamble and his group, and I believe this was his PhD project, reveals these themes of disrupted agency and identity. And you can hear these in John's conversation: invalidation, difficulty interpreting symptoms, persistent struggle for control and coherence, emotional distress, and uncertainty about the future. And so we do know something about resolving uncertainty here with free energy principle and active inference. And so I think this is the right way to go forward with this. So I don't know if any of you 80s movies fans, but I'm thinking, we're going to need a bigger model if we're going to try to do all this, right? So we want to unify these perspectives, and we want to also make sure that what we are describing is biologically plausible, clinically accessible, and also revealing of targets. And importantly, being able to test these ideas. And so I think what we're trying to do here is build a framework, sort of phenomenology connected to this sense-making process that makes sense in the clinic. And fortunately, there's been a good pathway here laid by Stillwell and Harmon and Jorge. And this has been applied in the clinical practice, so it's kind of acceptable, and it's very compatible. So tying in the agreement, the points of agreement between enactivism and ecological psychology, and moving forward and making those literally actionable with the free energy principle is where we're heading here. So enactivism entails this 4E, perhaps 5E, depends on your viewpoint, perspective of sense making, right? And so the person is embodied, embedded, extended, and active and emotive. And so what does that mean? Well, I think that We're going to unpack those a bit here, I think, and try to tie in the clinical relevance here for the person with dizziness. First of all, the embodied is first and foremost in that this is a counter to our tendency to be, my tendency to be both neurocentric and vestibulocentric. So we're thinking in terms of, okay, how is this vestibular system, or how is the nervous system affecting the person? And I think that there's more to it than that. We want to look at the whole person, particularly when we think about our pathophysiological model of dizziness. We see that there's more than just brain activity going on here. And importantly, the person is embedded in their lived world, in the environment. And that's really important for someone with persistent dizziness, because they often have contextual or environmental triggers. People have dizziness in the grocery store. They have dizziness on the stairs. There are very specific environmental triggers. In fact, dizziness is modeled in study under the context of postural threat, where they have people without triple PD standing on the edge of a platform, and they look very much just like the person with 3PD. So the environment is entirely important. And looking at these extended cognitive models, or extended cognition, sense making, it does extend beyond the boundaries of the mind or the brain, and even into the therapeutic alliance, right? And this importantly is inactive, and emotions are a component of that inactive approach here. And we're going to kind of go through this here as we go. So this is based on the embodied cognition literature. Having a body is necessary for agency. So Anna Sionica's work is really important there. The important patient narrative here is that these felt symptoms are not in your head. They're not just manufactured by your brain. There's more to it than that. You are more to it than that. And I think that resonates very well. Also, the body postures and positions are very important. And we do know that sense making is an embodied and active process. We talked already a bit about these environmental triggers. So moving forward here, importantly, what we get from ecological psychology is that we perceive and act in accordance with affordances, right? So there's a contextualized interaction. We see objects of our perception in terms of available action. This was kind of interesting and fun. This Clark and Chalmers paper, just looking at extended cognition. I'm going to kind of skip through that and just point you to that if you're not familiar, because I want to move forward and get into the active inference component here. The therapeutic alliance is an important concept here. As the person's cognition is extended, literally these interactions are capable of changing a mind and sharing a generative model. And I think that's really important as we think about our teaming with the patient in their process here. Importantly, the person is in this perception and action cycle. Perception and action are codependent. So perception guides action, which in turn constructs perceptions. And so we think about this to use that, the saccade model of perceptions are hypotheses and saccades are experiments. These are circularly connected. And emotion is intrinsically linked to active engagement. It establishes a meaning, a context, a value to our lived world and to our interactions within that world. And so we think about sort of our actions are motivated by our emotions. And I think that's really important, because in the clinic, we often think about emotions as being sort of barriers to progress, as if one could just get over their emotions and then that's the path to recovery. And that's really just based on the work that shows that people with persistent dizziness also have emotional components to what's going on. But really, I think if we can look at this through this lens, we can see that emotions are intrinsic to the process of sense making and the lived experience. So how do we resolve uncertainty? Well, you all in this group here know better than I, but I wanted to put this out there that this is based on a Bayesian mechanics here, right? So resolving uncertainty. So what state caused this observation, right? So in other words, what are the causes of the feelings that I have right now? And that's based on a generative model I have. So precisely my beliefs about my prior beliefs, and coupled with the likelihood of this is what I would expect to see if I'm in this state, right? So making the leap here, again, this is your world, but the person is now engaged in active inference, which is a step forward from Bayes in that now the person is actively selecting plans. They are actively, in a sense, bringing about their perceptions. And so the two driving questions for sense making here for active inference is what is the most accurate, parsimonious explanation for what I'm feeling, and what will I do next? And so this is what makes us agents, right? So I'm going to make some simplified assumptions that minimizing free energy is minimizing prediction error. And the prediction error is simply the difference between what I predict and what I observe, or my sensations. So we see this model of circular causation here, where there's this interaction between the person, the embodied agent, and their lived world. And there are these boundaries here, the Markov blanket, if you will, with observations and actions. Importantly, the actions themselves that are selected by the person are also creating sensations, and therefore driving observations. So basically the person is changing the world and changing their sensorium through selected actions. And critically here, this idea of precision is what kinds of data am I expecting when I move? What kinds of sensory observations do I expect, and am I confident in them? And this is critical for agency, in that the person understands, okay, I am the cause of my sensations. And so getting into precision here, it's an important concept as it relates to active inference. So it's the inverse of the variance, or really like kind of the inverse of my uncertainty. So how certain am I about what I'm seeing? And so I'm weighing these inputs, and I'm influenced by priors, and this psychologically corresponds to attention and is contextualized by my beliefs. So these ideas of I'm going to perceive sensory information differently. I'm going to treat them differently from a precision standpoint, depending on the environment where I'm in. So we can see here this kind of fun example of sometimes the precision is afforded to us just naturally when we see something here that is a bit imprecise, a bit out of context, and actually we can make sense of it with increased precision. So we can selectively do that, or we can have it afforded to us, and there's usually a trade-off there. So why is precision important in dizziness? Well, in general, sensory evidence of inaction must be suppressed for movement. And so this is multimodal. So when I go to move, I need to suppress evidence that is suggesting that I'm not moving, right? And I think here, with regards to the person with dizziness, or you could extract this to the person with pain or any hesitancy, that there is an avoidant behavior, possibly because they're attending to the evidence that they shouldn't move, right? So my symptoms are now precisely evidence that I shouldn't move And so therefore, I'm going to stay in this state. Or in John's case, I'm actually going to lie down. And so I think this has implications for therapeutic strategies. So what is agency? It's one's perceived control over their bodily actions. I'm the cause of my sensory observations. I can plan and select the appropriate path forward here in terms of movement. And it's predicated on this idea of sensory attenuation, because in order to know that I am the cause of my actions, I need to be able to differentiate. And this is how precisely we differentiate. So I want to show just kind of a clinical example of sensory attenuation. This is the vestibular ocular reflex. So head-eye reflex, I move my head, my eyes move in the opposite direction unless I want to make a gaze shift. So if I want to look across the room, if my eyes are constantly moving opposite of my head, then that's going to be a problem. So this just kind of shows that, that there is suppression of the vestibular ocular reflex here, the EMG, so to allow the saccade and then to allow one to shift their gaze. So if sensory attenuation and precision are tied to attention, what shifts first? And so I'm thinking that before we make this gaze shift, before we suppress this important reflex here, in order to have directed action, we need to first shift our attention. And so importantly, we're saying, well, what would I expect to see next? So getting to the clinical example here, this is someone who has had acute dizziness. So this is just looking at somebody with vestibular neuritis, which is a condition which has a sudden disruption to the vestibular system. And the person with this is experiencing vertigo, very sick and dizzy. It's very debilitating for the short term. It can go on to something like 3PD, and they can also recover. So let's unpack that recovery process to get a better understanding here. So here is, this is in Adolfo Bronstein's lab. Many of you might know him and his group. They are being, these are people who have acute vestibular neuritis. They are still 2 days into their ordeal. They're still dizzy. They're still sick. I can't believe they volunteered for this study, but they get into this chair. They have their vision occluded. They have sound occluded, and they're looking at vestibular ocular reflex, and they're looking at perception. They're being asked, when they're spun around in this chair, turn this tachometer, turn this wheel in exact proportion to what you're feeling. So it's a measure of their perception of motion. And you can see here that even early on, this gray line at the top here is this is the control group. But you can see that regardless of the direction which they're spun, these individuals actually are able to perceive motion accurately. And so what happens there? Well, this is really, I think, kind of the key here, in that you can see that the top line being, again, this is the control group, but look at these two lines here. So this is the affected side. We would expect it to underperform. This is just looking at vestibular ocular reflex activity. And you can see here that the intact side is actually attenuated. So this is the side that should be firing on all cylinders. It should look like this one up here, but the reflex is being attenuated by probably by the action, actually, but it's being attenuated to preserve perceptual stability. So what happens with the person with persistent dizziness here? And this is critical. So we can see here that perception in the top bars, this is looking at just threshold for detecting motion. And so you can see here that the recovery process is predicated on basically attenuating the reflex, attenuating the sensory inputs. And you can see here that actually there's like an over attenuation, so that the person with 3PD seems to be more sensitive to motion in this condition. They actually are better at detecting motion. And so that is seen as a failed sensory attenuation. And that is probably one of the key mechanisms of what's happening with the person with 3PD. So trying to put together the lived experience and the presumed physiological mechanisms. We can see here that there's a triggering event. So it doesn't have to be a vestibular issue per se. I felt woozy, I felt fatigued, and it's sustained by beliefs, ultimately, that there's no way forward here, right? And so I would say that that is a metacognitive belief that is emanating from and consistent with everything else that's happening in the person. And there is this excessive precision, just the motion sensitivity, and also the attention to the symptoms. I think when somebody gets into this state, you can refer to it as hypervigilance. It's really just trying to make sense of the internal world by sort of increasing the attention to what's happening there. So there's this amplification. You could say that the precision of the prediction errors has been increased. And then there's this misattribution and loss of agency from the perspective of feeling as if the ground is moving, and then also feeling as if I'm just losing control of my life. I have nothing to do but to lie down to make this better, right? And so therapeutically, which beliefs are we going to update? And so I had this characterized as the left column is our personal beliefs and the right column is our subpersonal beliefs. But I think there is this scale and variability here at play here. So I'm just going to say that we have all of these beliefs that we can address in the clinic. What is the most relevant? What is the most accurate and the least complex is another way to think about that. So restoring one's beliefs about agency is critical. It can be initiated by naturally in the clinic with the therapeutic alliance, good listening and validation. Good therapeutic discussions are going to bring about this shared generative model. We can model these interactions of the patient and the provider. Therapeutic touch, exercise, and manual tasks are going to help restore agency and doing things like providing choices. What is important to you? What should we work on first? What would you like to do? And this is critical, and its subtlety could kind of undermine it here. But sensory attenuation, there are probably a lot of clever ways to bring that about. And I think that we can work on attentional focus strategies. We can work on different enriched environments. But I think at the end of the day here, choosing to ignore the sensory evidence that I shouldn't move is a really ripe target for someone like John, where the choice is, should I lie here and be completely comfortable? And so there's sort of this explore exploit trade-off here, right? I can exploit what I know to fix my symptoms, or I can explore for ways to move forward, but I've got all this contradictory evidence that moving is not going to be good for me. So I think I'm going to choose that. And so it's a very understandable conclusion. And I think that where we come in as providers is, let's facilitate movement exploration. And importantly, movement exploration that is designed for success. And we can talk about how that might be in contrast to something like exposure therapy, or we can talk about how it might be very similar to that. So as far as clinical targets for beliefs, I can work on one's illness beliefs. I can work on their feelings of resilience and their expectations that things are going to get better. But I think at the heart of it, they need to have that successful experience with movement and feeling like, yes, I have some control over this. And so that's where we literally just break it down into very simple, structured, therapeutic movements, if you will, and basically overcoming that sensory evidence that I shouldn't be moving, that there is something wrong with the movement. And even in the context of feeling dizzy. So I still think it's an important nuance there we can definitely discuss. So why self-efficacy is so important, it's across multiple diagnoses, it's measurable, it's specific, it's changeable. We're not talking about changing one's personalities, or if somebody could just think about their disease process in the right way or their condition in the right way, then they're going to be better. And if you're not better, then there's an assumption that you just don't understand, right? I think it's more like, okay, I understand enough about my condition to where I can now start to explore and then start to importantly experience success. So I want to just share John's belief updating here.
Do you still lie down when you're symptomatic?
Sometimes, but other times not. What I do now is I move my body. I do exercises, and that kind of re-energizes me. Whereas before, I would just go lie down because I felt like I was so depleted of energy that I thought it's the only thing I actually can do, and it feels okay. I can get some relief.
So what of the emotions? I think there's a lot made of the emotions, and I certainly don't want to, kind of relegate them to something that is trivial. I'm saying that they're important, but I think that there are, in a sense, there's good evidence here that they are scoring one's belief about their ability to resolve uncertainty. So their confidence in their generative model, if you will. There's a lot of good work on that. And so these emotions are also reflective that, I don't have sufficient self-efficacy here, right? I don't think I can successfully manage and bring about the right action plan to get to my preferred observations or my preferred outcomes. And so we can model that, and there's been a lot of great work by this group and colleagues, Brian Smith and Casper Hess from Maxwell Ramstead come to mind, of course, Carl, and looking at one's confidence in their sense-making process. In a sense, like I am as an embodied agent modeling and keeping track of the precision of my model, right? So we can quickly get caught into these infinite loops here, but I think it's, in a sense, it's this metacognition that sort of says, okay, how am I doing? How do I feel about my ability to resolve uncertainty? How do I feel? Do I have the resources? In other words, does my model of the world fit? And can it bring about the right action plans? And so I just want to conclude my portion of this by just having John share kind of the whole story kind of wrapped up. It's a little bit lengthy, but I think he touches on some important points that we can leverage here.
Okay, so you were talking about how you're viewing dizziness, and I just wanted to hear a little bit more.
I try not to fear it and try to actually welcome it, and then do things like exercises, things that I've learned in physical therapy, balancing exercises, movements that challenge the feeling of dizziness, of motion sickness. And when I do that, I can deal with it better. It doesn't eliminate the symptoms, but it kind of makes me more comfortable with the fact that they exist, and that at least I'm doing something positive to try to deal with the problem. And I think that even if the problem doesn't go away, it almost immediately gets better. And I feel much better about it. I feel more optimistic that there's a solution, or that at least I can control it and live with it comfortably, because I'm not living in fear. I think fear is the biggest problem to recovery. And I can only reiterate, like, meeting what I was afraid of, and that's that perspective has really helped me manage the situation. I use the word manage because I want to be honest and say I'm not cured, and I might never be cured, but I'm managing the situation much better than I ever did, and I'm actually I'm actually happy again and optimistic that that I can live my life with this symptom and live it happily and do the things that I like to do, especially outdoor activities like today, taking a hike and feeling physically fit.
So I want to conclude actually with this and just put this up during our conversation, trying to think of a way to model this process here. And so this is this inactive inference model, if you will. And so I'm going to go ahead and conclude my portion of the talk and just open this up to your valued input here. Thank you so much.
Thank you so much, Marc, for the presentation. Really interesting. So now we're gonna move to Q&A session and comments. So if there are any questions or comments, please raise your hand. I just have I'm curious about one thing. So let's see, this is kind of overall feeling I have, which is there's this descriptive kind of part of all this, which is integrating the whole situated cognition approach via this generative model and so on into the therapeutical description, and how to, in order to approach it better, or to give it a more fine-grained description of what's going on. How would you translate that, for instance, into a prescriptive framework that says, okay, you should do this as a therapist instead of that? Because it feels really hard to keep track of, control variables when you open up the environment, right, in which you are dealing with. So I'm just curious about that.
Right. I think that's a fantastic question, and thank you for that. I think it's difficult in a sense to be prescriptive on a granular level with this. I think it's difficult to say, okay, make sure you do this and then do that. I think it's that we have these themes, and so so I'm a physical therapist and work with other physical therapists, and so I think it's like, rather than, okay, we're doing this, and this sort of prescriptive, it's more, let's make sure in our way, in your way, in what you know as a therapist, that you're attending to one's self-efficacy beliefs. And so what might that look like? Well, it's going to look different for our John than it will for Sally, right? And so I think it's within the Therapeutic Alliance, importantly, getting to know the person and on that lived experience level, recognizing that these seem to be the themes across multiple patients. They have these concerns. So we can go back to the gamble work and then look and say that, okay, but these seem to be driving the engine of recovery. So we're looking at self-efficacy beliefs, I would argue. We're looking at agency, and we're looking at attention. How do we best get at those? There's actually, if you don't mind indulging me, I can kind of put that up here. This optimal theory is very familiar to the world of physical therapists, and so this is one way to sort of point. Again, this isn't prescriptive either, but I think it gets to, okay, are we in the way of the nuances and the personalized interaction? Are we attending to these features? And if so, that seems to be our evidence base. So for someone like John, the feeling that he's losing his balance was most critical. So how do I help someone become very to feel very self-efficacious in and around their balance? Well, as a physical therapist, I have that in my wheelhouse. So how do we do that? And we continue to use these ingredients here. For other folks who are younger with 3PD, it may be that they are feeling difficulties in complex environments. So how do we come up with an action plan for when you're in a complex environment? How can we construct a more complex environment that will allow you to experience a little bit of that success and to sort of play with these ingredients with attentional focus in particular to be able to feel as if, okay, now I feel more confident in my ability to bring about the types of experiences that I want.
Okay, yeah, cool. Okay, interesting. Yeah, I guess it has to be like more case by case somehow, because yeah, there can be lots of variants, right? I assume across patients and
Correct.
so on. So
Correct. So it's attending to the big picture themes here, I would say.
yeah, okay, nice, thanks.
I hope that's helpful. Yeah.
Yeah, definitely. Thank you.
Mm-hmm.
So yeah, I don't know if are there any questions or comments in the chat? Anyone? So yeah, then maybe I guess we can move to you, Carl.
Yes, we certainly can. This is an unusual TMB meeting because I've actually read the paper that forms the basis of this presentation. So this is more, I think, a celebration of the denouement of a series of meetings and sort of collaborative work and focus on this issue. I am mindful that Mark wanted to ask questions as well, so it may well be that the question and answer should actually be led by the authors of this thesis, just to drill down anything which could be unpacked further or ask if anything has been missed. So I'm going to give a very brief feedback. And as usual, just go through a couple of papers that may be or may not be useful, but with the intention of actually stopping early and then passing it back to Mark and Mick and everybody to see if there's anything they want to unpack a little bit more, just to make absolutely sure that we're all on the same page. The, my just to pick up this theme, the sort of 4E holistic perspective. I thought that was dealt with very gracefully in the write-up of these ideas, in the sense that active inference certainly is shares exactly the same kinds of commitments that you would find in the embedded, extended, and embodied and active literature. And also in virtue of things like emotional inference and interoceptive inference, also the emotive aspects of that sort of um, sort of situated approach. So from my point of view, that is a natural way to frame things, and I thought was done very nicely in the write-up that I read. Um, the other sort of feedback is slightly more quizzical, in the sense that the description of sensory attenuation um, had some really intriguing aspects. I'd forgotten about the VOR work, um, and particularly its relationship to persistent dizziness. Um, that was fascinating. Um, on the quizzical side of it, there was the way that it was framed in the sense that the phrase a number of times was attenuating reflexes. Um, and my mechanistic understanding of sensory attenuation in the context of active inference means that it's the exact opposite of that. You need to attenuate sensory precision in order to release or enable the reflexes that underwrite willed action and non-willed action in the form of, say, autonomic reflexes, or at least those reflexes that are mediated by smooth muscle as opposed to striated muscle. Um, so I'm just going to sort of rehearse what we've discussed before, just to make sure that it is consistent with the description that attended the introduction of the VOR as a really nice sort of, if you like, example of sense attenuation and its putative link to persistent dizziness. So the way that we would model this, both conceptually and in silico, would be that you've got some prediction errors from the primary afferents, from your sense organs, and they are compared with top-down predictions to form a prediction error. And then you've got a choice. You can either send those prediction errors back to the actuators, so closing a classical reflex arc, by attenuating, well, you can either send them back or you can send them up into the CNS for belief updating, so you change your mind. So the attenuation that in the active inference literature is of the ascending prediction errors that change your mind. And if you attenuate those, the only way you can minimize, or the way that your prediction errors are now minimized, are um, unconsciously, in every sense of the word, through the reflexes. So you can either resolve a prediction error by changing your mind and saying, oh, I'm dizzy, as the best explanation, or you can attenuate the ascending prediction errors ascending from, say, the spinal cord or the brainstem, um, so such that those prediction errors are now left to drive reflexes. Let's not take dizziness. Let's take sort of cardiac acceleration. I can either be actually, no, I can't be aware of cardiac acceleration. Postural. Anyway, I can either use, I can either attenuate some prediction errors so that they drive an autonomic or motor reflexes and act upon the world, or I can fail to attenuate them and thereby change my mind so the prediction errors are resolved through changing the top-down predictions. And of course, that subverts the reflex. So by failing to attenuate the ascending prediction errors, I undermine and remove action as a way of resolving them, which seemed to fit perfectly with the framing right at the beginning, that the control theoretic model seemed to speak exactly to this, that there is, on the one hand, an inability to um, ignore in the sense of attenuating the ascending prediction errors to the central nervous system, as manifest in terms of lowered thresholds, hypersensitivity, and all that good stuff, whilst at the same time losing the reflexive, automatic, in the flow kind of subpersonal responses that just keep us balanced and homeostatically aligned. And of course, I haven't now got access to those automatic responses, which I would not be aware of because I've attenuated. I'm ignoring. I've attenuated evidence that I indeed needed those reflexes. So it's paradoxically, because I'm now attending to these particular prediction errors, I'm denying myself the opportunity to smoothly and reflexively respond to eliminate them by acting upon the world. And of course, you now know that, so you've now lost. You're now aware that you're no longer able to control that, and therefore there's a loss of self-efficacy. And of course, once you've got that, you've got all the uncertainty about the consequences of my action, and then the anxiety, and then if you learn that, there's irreducible uncertainty out there that can become chronic, and then you get to the persistent phases of these sort of dysfunctional inference or aberrant inference syndromes. Um, so. It would perhaps we could just go back to the VOR slide, because I found that particularly intriguing. So what the story here is, that the sensory attenuation effectively is necessary to realize your prior intentions. So another view of what I've just tried to summarize is that you have some prior belief that I am at the initial stage of executing some motor narrative or some movement. And that means I'm going to send predictions down which correspond to the consequence of enacting that movement. That sets up a prediction error, and that prediction error just drives the classical reflex arcs to fulfill that prediction. If I don't attenuate those prediction errors in terms of them coming back, then those ascending prediction errors will now change my priors so that my intention is now dissolved. It's self vitiating in the sense that as soon as I intend to move, immediately I sense I'm not moving. So that means, oh, my prior belief about movement was wrong, and now my posterior belief is I'm not moving. I'm going to go and lie down. To take John's example. Um, Actually, that's not a very good example, because lying down is taking volitional control over. It's another way of inducing sensory attenuation by actually just, reducing those prediction errors just by, not eliciting vestibular or possibly even visual prediction errors at all. But so on that view, it's not so much about attenuating the reflex. It's more about enabling the reflexes that keep us moving, keep us, so in one sense, in the flow continuously and subpersonally, bodies engaged homeostatically at every level. Uh, in a way that, I repeat, sort of underwrites our sort of motoric and autonomic homeostasis. So you're right, it's the opposite of attenuating the reflex, as it were. So can I just look at those results where you had the hyperacuity? I think
Yes.
wonderful, yeah. So
This one, or there's also the next one that looks at it a little bit differently.
well, no, this is great. So we're talking about right? So yeah, so sensory attenuation usually in psychophysics is assessed by um, perceptual ratings, and usually if you have a failure of sensory attenuation, you're more veridical, um, which
It's probably like the force matching for dizziness in a sense.
yeah, no, that's exactly. I got a paper about force matching up just to remind myself to make that connection. And then when I looked at the top thing, I thought, yes, that's exactly what you'd expect, in the sense that you the perception is right. Perhaps you can talk us through this. Could you tell a story along the lines of the force matching illusion that
Yeah.
reveals a yeah. Carry on.
Yeah. So my understanding of the force matching is that normally when we have to press on, something, right? And we're going to kind of underestimate. I get this wrong. We underestimate the force that we are applying relative to the force that's being applied to us. We actually overpress in a sense, right? So here, actually, I see this as this is a matching paradigm. I think that this wasn't intended to be. This was intended to be perception. This is what the person's perceiving. But as soon as they're turning the wheel, now they're engaged in action, right? So they very well attenuated sensory input as soon as they started the process. So I think that the process makes it more of a force matching than a pure perceptual task. But nonetheless, it's basically you could say it's a rotation matching. So this is what I feel, and so I am going to match that by turning the wheel. Now we would expect the side that's been affected by the neuritis is going to look like this. It's half of the full capacity, if you will, of the VOR. But what we wouldn't expect superficially is that this intact side, so the side that was not affected by the neuritis, we would expect maybe superficially to look more like the control group, right? But in fact, what you can see is this attenuation of, well, so for here, this is where I am having a difficult time, Carl. If you could help me out here, that I'm seeing this as attenuation of the reflex, because the reflex should be the activity should look more like this. So help me understand what because what is the sensory component here? That's the difficult thing, because there's separate pathways for VOR and then self-motion perception, which is vestibulospinal reflex shared pathway. So you could probably quite readily say that it's a attenuation of prediction errors, right? That would be more accurate. That encode potential self-motion perception. So what I'm trying to understand is what is happening to the actual vestibulocular reflex, which quite simply is just the eyes moving in the opposite direction of the head. And I'd say that that's probably an oversimplified explanation, but that's how we learn it.
Right. Yeah, no, I was hoping you clarify it for me, because it gets very complicated, doesn't it? You're absolutely right. You know, there's the psychophysics of, if I am underestimating the intensity of self-produced acts, then I am going to report them as being greater when produced by something else, because I've underestimated the intensity. And it does get very, very, very complicated. But just on a simple-minded view, I mean, the bottom panel certainly shows the if we now, yes, so the sensory attenuation has actually attenuated the reflex. So that's perfectly okay, which is exactly what, just in a very simple-minded view, that's exactly what I was saying, that if you don't attenuate the ascending prediction errors, if you fail to attenuate the ascending prediction errors, that will take the pressure off the reflexes. So you will be, a failure of sensory attenuation will attenuate the reflex. And that seems to be what we've got here. So the eye velocity seems to be attenuated in the people with on the affected and the yeah, I see. So you're using the attenuation of the reflex as what I would as the corollary of a failure of sensory attenuation of the ascending prediction error. So yes, it all is internally consistent. Good, but on a very simple-minded view. So, Mark, what I'm saying is, if you can tell a story where the VOR is something not it is just a measure. It's not a psychophysical measure. It's actually a behavioral measure of the sensitivity of the reflex, and that will be compromised if you fail to attenuate the ascending prediction errors, because the ascending prediction errors undermine the motor control, the predictions that drive the reflex. so that you will get an attenuated reflex and a failure to respond motorically in this, or with oculomotor responses, and or with the vestibular or VOR in this particular case. Is that the perceived force is too big? Now, who's actually doing the force? Yeah, presumably it's
This is externally driven. And so let me correct the narrative a little bit that maybe I misconstrued. These are patients who recovered, right? So this is looking at, so this is actually looking not necessarily a failure of sensor. This is looking at actually a pro-adaptive, if you will, attenuation, right? So we could say that it's a prediction error attenuation to bring about perceptual stability, right? So the side that should look like the control group does not, because there is I would say the proper attenuation. So you might take someone who then did not recover, and you might see that they have this affected side necessarily, right? Because that's the condition, the inputs have been disrupted. But you might see, and I would expect to see somebody with that has persistent dizziness, or is at risk for, this might be the characteristic, right, that we would see, that their unaffected side, their intact side, would look more like the non-dizzy control group. So this, in other words, is a failure of attenuation of exactly what we're trying to resolve, right? But there's a failure of attenuation, that I would say of prediction error would be probably the most accurate sensory prediction error, that is now driving this desperate or disparate separation of the affected side and the unaffected side. So now you have this ongoing asymmetry of reflex deployment and of perception. So that would be the story I would tell, but that is I'm making that latter part up a bit because we don't have the data there. Mick.
Yeah, I think one of perhaps apologetically, I'm adding to the complexity. I think the assumption here is that following these sort of vestibular neuritis conditions, that actually you do have an intact side and a non-intact side. I think there's evidence that whenever we have a neural injury, that actually there is some mirroring of that injury to the opposite side. So I think actually that this diagram to me looks as though it's actually explaining that you've got actually in the so-called non-affected side, you've actually got a degree of compromise which is not as great as on the affected side. My background, as some of you know, is in sort of pain. So I was with Pat Ward's group and Steve McMahon. They rather famously, together with Martin Kolzenberg, who perhaps is still at UCL, wrote a paper on does the left side know what the right side is doing, where they were explaining these sort of cross site pathologies, so that you will seldom see in neural injuries one side being affected without some carryover to the opposite side, even though there's no pathology detected. So that perhaps complicates the picture, and apologies for that, but it may also have to be taken into account when we're looking at the attenuation of the reflexes as shown in the lower diagram.
That's a good point. Nick, do you think that carryover, that there is, I'm just asking out of curiosity, that there might be evidence that is, in a sense, a reconciliation, if you will, of for purposes of restoring a bit of symmetry? In other words, it's adaptive, not necessarily like collateral damage, to describe it.
Yeah, it's not classically been viewed as adaptive. It's been classically viewed, if anything, as maladaptive, or on a scale of maladaptation. But certainly it's underpinned by plasticity, which obviously have that bidirectional nature, and often is left to a judgment call on the side of people reporting what they find. So my own my own knowledge of that from my own work, which was particularly centered around neuroimmune crosstalk, was that actually it's a maladaptive process where we see changes on one side being reflected to a lesser degree on the opposite side. So again, apologies because I'm maybe throwing in an argument of complexity here that takes us away from the central sort of discussion.
Well, I mean, I think this. Forgive me, I can't remember. Is this example in the paper? Is this graphic in the paper?
The graphic is not. No.
I mean, you know, to my mind, this adds, you know, a really useful empirical link between the sort of, you know, the theoretical treatment of how patients selectively or fail to ignore and their emotional responses to that failure to ignore a loss of reflexive control over their bodies, and the neurophysiology that could be traced right back to the gate theory of pain, you know, that involves well-known synaptic and plastic mechanisms, or at least, you know, gain control of synaptic efficacy. So I think this is quite an important, you know, something that will engage neurophysiologists and see how it connects to the lived experience. I think this is quite a useful one. I'm still not quite sure how to tell the story because you're more confident in telling the story than I am, given.
Well, I thought I was.
Yeah, well, no, it persists with it as long as it's understandable to you know, to the reader and to me.
Right.
I guess what I'm a bit confused about is that we're talking about a measurement that pertains to a reflex as measured by eye responses to moving the head.
Right.
So
Right.
how do we get out of that? What is the affected side versus intact side?
Right.
How do you get the lateralization from a bilateral eye movement? Presumably they're not measuring each eye separately.
No, what they're looking at the eyes being yoked, right? But I think importantly, this is and I don't think I introduced it clearly, that this is a presumed mechanism of early adaptation for a peripheral vestibular problem. So this is not 3PD. And so I think that this is really looking at what does the vestibular system do in response to an insult that is unilateral, right? So this is someone who we're having bilateral cranial nerve 8 working properly, and then all of a sudden one of the sides goes out, right? So we call that a neuritis, and so it's this acute hypofunction that's unilateral. This is what folks who recover seem to do early on to try to reconcile perceptual asymmetry. Now, VOR is not measuring perception, but I think it's giving us a sense of what is happening to the essence of that system motorically when subjected to rotation, which is going to activate said system. And we're kind of probing, okay, what's the response? What's the response of the side that is affected by the condition, by the neuritis? And what is the response of the side that we would assume superficially is intact? And so what we see here is that there's a successful, I would say, attenuation of the intact side in order to preserve, or in this case, restore perceptual stability. That is different. And if you don't mind, that is different from what we're looking at here in a sense, in that we see that there is evidence. So this is just looking at click a button when you feel like you're spinning, right? As soon as you feel like you're spinning, you click a button, and which direction are you spinning? Everybody was accurate about which direction, but the person with the group with triple PD were more sensitive, so they had a lower motion detection threshold. So that suggests this is what's actually suggesting the failed sensory attenuation. The other story was to sort of present the dichotomy in strategies that seem to be happening under the hood here.
Yeah, yes, absolutely. Yeah, this second slide is, it tells a much more straightforward story.
Right.
And I'm sorry, I just got so intrigued by the VOR. I'm still a bit confused. How do you how do you measure? What does it mean by the affected versus non-affected side? What's the
Okay.
intervention or the measurement that
Mhm.
allows you to assign those curves
Ah,
to affected versus non-affected?
So subjecting the person to rotation in the direction of the so I have a resting VOR firing rate that is maintaining my static gaze stability. When I am subjected to a motion in one direction, the direction to which I'm being rotated is going to show increased activity of that particular side. So assuming that
Oh, I
my right
see.
side
Right.
is intact. So there's so what we're talking about with, and I don't think I set it up as, okay, this is vestibular neuritis. This is a condition in which one side is affected and the other side is spared. And so when I am subjected to rotation, let me use the opposite example. When I'm subjected to rotation in the side that has been affected by the neuritis, it's the hypofunctioning side, I do not have a robust response. Why? Because that presumably the afferent information is disrupted. Well, probably both directions, or there's a disruption of that peripheral nerve, right? If I'm rotated in the direction of the side that is spared, in other words, the intact side, I would expect to see a normal response, right? But I don't. I actually see that when I'm spun towards the side that is spared, it actually looks like it's trying to approximate the activity on the side that's been affected here. So I would say that there is some evidence of, well, there's attenuation there, right? But if I go back to this now I'm thinking about this a bit differently, that there is there may not be sensory attenuation in that they are perceiving rotation symmetrically. We've got to get Diego back in here now.
Before Andrew comes in, I say I didn't realize that you had a direction selectivity that was lateralized with the vestibular system. But just to speak to Mick's point, that if the sensory attenuation is to all consequences of movement, including reflexive eye movements, then it won't have that direction selectivity. It'll affect any consequence in any modality, including sort of right versus left reflexive movement. So that also makes sense.
Andrew, did you have a question?
Yeah, can you hear me?
Yes.
Yeah, just to say that this is supposed to be in the literature, the decrease in sensitivity to the intact vestibular nucleus static drive. This is supposed to be the way in which over a period of 24, 48 hours, 30 whatever hours after a unilateral vestibular loss, that the VOR at rest gradually tails away in the normal recovering person, so that there is supposed to be no drive to the eyes from the affected vestibular nucleus, but on the intact side you will still have a static drive which will be pushing the eye away, and therefore you're going to have resting nystagmus. And as I understand it, the literature says that over a period of 2, 3, 4 days, the intact static drive is gradually reduced, and the sensitivity to that static drive is gradually integrated into the nervous system. So there is a gradual cancelling out of the error.
And so this is reflecting that natural.
But this is slightly more
compensatory
complicated
process, yeah.
in the sense you've then got perception of what the movement is and a motor reaction to that on the wheel. So it becomes a bit complicated.
It is very interesting, but we have to keep it as simple as possible for the reader. Is there any nystagmus associated with these conditions?
Yes, during the first 48 hours. So this is presumably looking at that, as it's called, the central compensation, right? So this is this early compensation. They by this time their spontaneous nystagmus has resolved, and so this is sort of like explanatory. Well, what happened, right? And what happens if we probe the system? And so I think this is sort of looking at what Andrew was saying is, given that we see this spontaneous recovery, if you will, what is happening under the hood? And I think really the way to measure that, and also what is happening importantly with the perceptual component. So I think that this is the important thing is that this group was very interested and continues to be interested in self-motion perception and what they would refer to as the dissociation between motion perception and something you would characterize as more motoric, like the VOR. Motion perception being relatively more complex and harder to measure, so that's why you sort of have to ask. And so the only way to really ask is to have somebody probably trace what they're feeling like this. Now, as soon as you do that, you're going to drive sensory attenuation, which actually probably makes the case even more strongly that that's what you're looking at. Just by virtue of action having to attenuate the consequences of my movement. Mm-hmm. The perceptual consequences, that is.
Yes. Yes. Yeah. I mean, I think this is I mean, these all of this discussion and these examples, and of course the sort of the knowledge that we have or you have about these systems really puts a physiological mechanism under the theoretical arguments that you can then link right back to the sort of the holistic approach at the beginning of the paper. So as much of this stuff as possible that's until it starts confusing the reader, I think should go into the paper and put this put your knowledge in in the context of this conceptual frame. I think that will be really useful.
I think we do have this portion here in the paper, this Worthman study. Yeah.
Excellent. Just before I pass it back to you, just to make sure that if I take the screen, I'll just quickly go through the papers that I identified that I also checked were not referenced in the current draft. I don't know that there's much that you haven't covered, but I was sensitive to your question. Is there anything that you've missed? I don't think there is, but just in case you want to refer to sort of generic observations or comments, I put a couple of papers up. The sort of there was a mention of sort of the I can't quite remember now. Was it neuroendocrine? Oh, well, there were at the beginning and the end of the presentation and in the discussion, one notion that was certainly important in framing the nature of the disease was the distinction between those people who recover and do not recover. Um, and yeah, indeed, in terms of the nosology, the very fact it persists, I think deserves some comment, and I think you've already commented, but it struck me you get very similar um, arguments when looking at um, the the responses of the brain to different changes in precision or uncertainty. And very loosely speaking, um, you from a computational perspective, the uh, the brain can either realize in the acute phase that there is irreducible uncertainty around and can adapt to that so things become less precise. And then, if there is resolution, the responses to the changing situation are such that it discovers that, in fact, the situation is remediated. So, there is an appropriate resolution, and that the world has changed back to what it was prior to the insult or the traumatic event or the sort of the new onset of neuritis or um, whatever was the initial induction of, or yeah, the induction of some kind of uncertainty, which was initially difficult to resolve. But some people don't ever realize that, and then they they get stuck in a world model or a generative model, and in particular, their encoding of their uncertainty about the world in terms of the precision in which the world is always persistently uncertain. Um, and that leads to sort of, the chronic sequelae of always responding and believing that the world is unpredictable and there is irreducible uncertainty out there, usually causing withdrawal behaviors so that you never discover the evidence that the world, in fact, it has changed back or has become much more navigable and predictable than you thought it was. So, I don't know whether this has been mentioned, but this sort of basic theme just goes through the neuroendocrinology of this. You're right, you're using very much a precision-centric account of the angst and anxiety expressed both in terms of, the person, but also in terms of allostatic wear and tear and allostatic load from the point of view of the physiology and the endocrinology. So I thought it'd be, just a nod to the fact that, there is a rationale, if you like, that would suggest that some people might respond, uh, uh, some people might resolve, and other people might not if they get into a vicious cycle that precludes them from finding out that in fact they have recovered or that the world is not quite what they thought it was, being you know, having this having the fear of uncertainty or the fear of the unknown. In this instance, it's a loss of reflexive control over my body. Um, which necessarily introduces all sorts of uncertainty about the consequences of my actions. And if you believe this is now the new state of the world, the new way of things, and you don't develop therapeutic or engage in therapeutic strategies to um, uh, test alternative hypotheses, you'll be stuck with that belief, and then your pathology now becomes persistent, both psychopathology and as you demonstrated in the pathophysiology. There was a similar, yeah. I think you've referenced quite a lot of resilience stuff. Um, I don't know that we referenced Laura Harrison's treatment of a very similar notion, um, which again, she's just trying to understand why some people recover from uh, an unsettling event and other people do not. Um, and by unsettling event, it's always something to do with precision or uncertainty. So I can't quite remember the specifics of this, but they certainly look at different kinds of responses in terms of resilient and different kinds of resilience. So you can be resilient in the sense that you accept your world has changed. I thought John was a beautiful example. His world has changed, but he's resilient to the negative affect aspect of it simply because he's found a new way of resolving uncertainty. Whereas other people don't. They say, no, this is my life and it is irreducible, and they will expose themselves to sort of, chronic angst and chronic anxiety and possibly chronic stress. So again, just another nod to that sort of holistic aspect. This this I put this up because the importance of being able to deploy sensory attenuation not only, I think, underwrites the ability to engage reflexes such as the VOR, but everything else in terms of just navigating our body, in the short term under gravitational fields and around obstacles. But also, when, say, if you had some sort of neuritis or some kind of perturbation to the primary afferents, if you've now got inconsistent information from, say, the vestibular and the visual afferents that cannot be explained by your generative model, you've now got this rather unsettling situation where, again, you've got unexplainable sensory afferents or sensorium. This cannot be explained by your generative model. So whatever you do, you can't get a precise explanation. So you can respond to that by saying it's very imprecise, or committing to, if two sources of information cannot be reconciled under your generative model, then you can effectively attenuate one and commit to the other. So this is another really useful aspect of our capacity for sensory attenuation, not just to let the reflexes do, eliminate that prediction error for me, but also to selectively ignore things we cannot explain. Um, and this is nicely illustrated by things like the rubber hand illusion, where we sort of ignore certain proprioceptive inputs in order to ignore the fact the position of our felt hand is not quite what the visual information is saying. And that then permits a prior belief, yes, that must be my hand. That's a simple explanation for what's going on. This was studied at length by Jakob Limnowski using sort of virtual gloves, using virtual environments deliberately, not vestibular and visual, but here proprioceptive and visual, to try and deliberately perturb them in relation to each other and see how the brain responded. So I just thought this was a nice sort of experimental example of how the brain copes with irreconcilable multimodal data that underpins the embodied aspect of, in this instance, inactive inference. Again, you don't need to read this in any depth. This is a nice example of the importance of sensory attenuation in making sense of our body and, beyond, sorry, not only in enabling action or action through reflexes, but also making sense of our body when those sensations are not what we generally expect. Um, yeah, flow. We didn't mention flow. You didn't mention flow. I thought that was an interesting one because, of course, you could look at sort of normally walking and talking and doing one's woodwork as being in a certain kind of flow that things are going normally, and I can ignore lots and lots of information. Um, Whereas, of course, as soon as I cease to ignore certain unexplainable sensations, I come out of the flow and I suddenly become deliberative and I become sort of focused on this, and then you get all the attendant difficulties that John was explaining, and and they remind me very much of Mark Edwards, talk, when he was doing work with um, functional medical symptoms with sports athletes, professionals who suddenly couldn't play tennis anymore because they couldn't get into the flow because they were attending to every movement, and then of course they just could not perform, and this was devastating for them because their families depended upon their ability just to act reflexively and skillfully in an automatic way for to support them financially, and their whole self model had changed. They're no longer a professional; they're a broken athlete simply because they could not disattend to the consequences of their movement and get back to that automated, skillful performance that relies upon that sensory attenuation. That was me just wittering, but I was just reminded very much of um, Mark's stuff. Yeah, you've got this in the references, and I would try and connect it to interoceptive inference simply because again, 90% of the story about interoceptive inference rests upon precision and the ability to attenuate or a failure to attenuate, and this sort of yin yang between being very sensitive to my autonomic states and not being able to do anything about it reflexively, usually involving some kind of dysautonomia, um, um, and or not being aware of my body, but my body quite happily reflexively just looking after itself. This theme keeps popping up in certainly in interoceptive treatments or applications of active inference to interoception. But I think it's important because not only does interoceptive inference sort of underwrite or reinforce this sort of embodied aspect of the 4E account, but also the emotional part because in a sort of James Langian way, this will be interoception is an important source of evidence for your affect and for your emotions and the emotional state and that you infer yourself to be in. And I would imagine sort of dizziness would certainly come under this, come under this class. And if you can engage people like Anil Seth, then that I think would be a useful move. Yeah, have I pointed to this work before? Yeah, good. Okay, so it's just another example of this sort of yin yang between hypersensitivity, um, when you get a failure of sense attenuation, um, to certain bodily states that is accompanied by a failure, a failure of sort of autonomic reflexes in this instance. So we don't need to worry about that. And that was just to remind me to talk about the force mapping illusion. So that's good. So now I can stop sharing and pass it back to you.
Thank you for your feedback and helping me unpack some of these slides here. Mick or Jorge, do you have anything that you would like to ask? You're muted.
Not so much ask a question, but I think that we do need to probably delve a little bit deeper as a writing group into obviously the sensory attenuation story as suggested. Obviously, George and myself have previously written on the subject, so we probably also can extract from that work as well, George. I don't know what you think.
Absolutely. We can unpack a lot of that stuff, add it to the paper.
Yeah,
absolutely.
I can't help but see, as a therapist, how these are informative narratives. So something like sensory attenuation, we can try to understand that at a synaptic level. I think at that personal level, do you think that's a fair extraction of that idea that, well, one may be attending to any evidence that they should not move? Would you say that is kind of reflective of the scale and variance of this mapping from, I guess, to go back to your phrase, the synapses, the sentience?
So are you? Yes. No. I was taken with that aspect of the presentation, and I imagined this inherited or was nicely illustrated by John lying down. Yeah, and I think that's yeah. I think that I thought that was an important part of the narrative. I do think it's sort of a different part of the paper than the sort of physiology of sensory attenuation and the neurobiology. Um, but in the sense that now I am equipped with a sensory motor apparatus that's not working properly, and it's not working properly because I don't seem to be able to engage my reflexes in the way that I used to be able to. Um, and that means that I've got to now attend to what's going on and make sort of almost volitional plans in order to try to compensate for the loss of the fluency that I once, be like the brakes on your car no longer working, or the steering wheel being a little bit, just not responding in quite the way that so you have to concentrate. And now I know I'm concentrating. Um, and not only that, but I'm concentrating because I am now very uncertain about about the reliability or the precision of my car. And that, of course, will have a profound effect on my self-model and on the fear of uncertainty and all of that kind of thing. One way to render that uncertainty impotent would, of course, just be to stop driving the car and go and lie down in bed. But of course, that's not consistent with me as a good woodworker. I thought the John story was brilliant. I mean, if you could actually have that in a box to provide that sort of patient first narrative, um, and just link that to all the sensible sort of or commonsensical almost aspects of um, self-modeling, under active inference, and all the consequences that hierarchically entail themselves in a nested way. So you have to make sense of all these things. Why can't I know, you know, and that comes back. I remember that our very first session, Mark, that brings us right back. So that complete story now becomes a scaffold for the therapeutic interaction intellectually, allowing them to mentalize why this is working, why lying down works, or why certain postural responses, or why a sense of control suddenly now makes you feel better because you've resolved uncertainty. You now know more precisely the consequences of your action, and indeed, you can counter the. And so, if you take the patient through the narrative in the paper, make them read the paper, I think that that would be another holistic level of engagement. Is that what you were driving at?
Yes, that's great. Thank you. I mean, my primary question was how to tell a better story, and I think you've definitely pointed to a lot of ways in which it can be improved upon. So this is all very helpful. I thank you. Andrew.
No, hi. I loved it. It's really interesting. Can
Thank
I
you.
just suggest that canalization concept of the Carhart-Harris paper was really useful here about this kind of wanting to lie down rather than spend the energy to try and explore and do something else, and get some sensory input, because you don't trust the sensory input that's going to happen from your actions.
That's a very good point, isn't it? Yeah. So the lying down is exactly the kind of behavior which is this pernicious. It denies you the opportunity to find out the world is change or is changeable. And of course, if you don't explore that, then you will remain in this sort of persistent chronic state of That's a very good point.
I think the therapeutic narrative sort of takes on a turn at that point, because when somebody is committed to wanting resolution of symptoms, we recognize, okay, well, you have that down. Now it seems like that's incompatible with other goals, right? With other aims and to use your term, preferred observations, right? So then there has to be a commitment to a commitment to a more difficult path in which I'm now realizing that my exploitive strategies are inconsistent with who I am, and so now I need to redirect to and recommit to the action policy that is not necessarily going to initially bring about the resolution of symptoms, but it's going to resolve uncertainty in other areas, which are ultimately the preferred outcomes.
Yeah, I mean, you mentioned intrinsic motivations, and certainly you've now got the expected free energy. So you've got that sort of epistemic affordance as a nod to Gibson, but in a slightly elevated kind of way, that to explore, to understand yourself better, yourself, your embodied self. Has its own intrinsic motivation, but it does require you to relax any precise beliefs. Coming back to the canalization notion, that this having symptoms means that that is surprising. If I behave in a way that elicits symptoms, and I believe I'm not the kind of person who has pathological symptoms, I have to set that against the intrinsic motivation to respond to those epistemic affordances. What would happen if I did that? But you've got that equation there now, so you can play around with that one.
Yeah.
I think what's interesting is I should out myself as someone who suffers Meniere's disease. So I've had many of the same experiences, and that balance between after a Meniere's event where you want to lie down and you do nothing, and then contrasting that with the epistemic foraging need to live a normal life and to be engaged and to go about and to recover, if that's the right term, is a real sort of tension that John, myself, people who suffer these sort of episodes have to go through. And when is the right time? When isn't the right time? And that's very difficult to achieve. But maybe that's where we can try to understand and offer some advice going forward, and to people like myself, like John, etc. But yeah, we also, perhaps talking for John and listening to his story, he obviously has a high self-efficacy, and that's not necessarily affording that to myself, but you acquire that if you want to re-engage with the world. So you have to have that sense of self-efficacy and agency to push yourself to forage again.
Yeah, if you could get that in a box, that would be really useful. Yeah,
you can do that, and I think that we tend to frame these discussions like, and he lived happily ever after. We don't know. I can phone him up and he could be having a bad day. So I think that it captures that. I think you did see the in the moment self-efficacy, and I think that gets to the point of self-efficacy being something that also needs to be sustained and maintained, right? And so that's looking at the tune-up process and so forth. So I think that's an important part of the story as well, that we simply don't know. We're looking at a moment in time. But I also think, Mick, to your point of your lived experience and looking at someone like John, this is purely clinical, but I think affording someone the idea that as someone with agency and self-efficacy, you may choose to lie down, and that is not necessarily a bad thing. Sometimes you need to feel more efficacious, and maybe that's your way for that moment. So it's that balancing act. And I think that we tend to, clinically speaking, think that, well, there always has to be an active approach, and there always has to be this, movement towards, something like that. But that could very much be consistent with self-efficacious behavior, that you can deploy those strategies from time to time with no feeling that, oh, I've failed. It's okay, I'm doing this because I am choosing to do this, and I am, in a sense, it's indulging the reward for a bit, and then coming back to, okay, so now I have a woodworking, I have something to get back to, right? So I think the nuance of that is is important to explore as well.
Yeah.
I don't have anything further.
Then we'll hand back to our glorious chair so we can give you a round of applause.
But thank you so much, everyone, for the discussion. Was super interesting. So yeah, let's give a round of applause for Marc for the presentation. Thank you so much. Thank you, Carl, always for your comments, and thank you, everyone. See you, everyone, next time then.
Okay, thank you all very much.
Thank you. Bye-bye.
Thank you.